Marsal, can you start the recording?
Yeah, done.
Okay. So when we're not sharing slides, would everyone try and put their screens on gallery and hopefully have your cameras on so we can see you and get to know each other. So my name is Rhea Markowitz, same as it is every month when we meet. And I'm from the Georgia Cancer Center, and I'm part of the teledermatology program. Here we are in our hub conference room. So Dr. Patton is usually here with us, and we usually co-facilitate the session, but he's not here. So he has another commitment. He may pop in as we in a little bit, but I will be I'll be going as our solo facilitator today. So I would first like to welcome our TeleDerm clinic healthcare providers. So if you can give a wave as I mention your name, is Dr. Sam Whaling on? I guess not. Guess he's not here yet. Hopefully he'll show up. Lori Hutchins, I see you. Say hello. Maisha McFarland. There you are. Sabrina Watkins. Don't see her. She may still be on leave. Stephanie Cawthorn, are you there? I thought I saw Stephanie's name. I see a Stephanie, but there's no camera. And Carolyn Jones, are you there? Nope. Floyd Soriano and Phyllis Solomon. Yep. I see Phyllis's name. Yep. So welcome, and let's see, Billy Stout. I saw, there you are. And John Ferrier. Not sure if you're there. Anyway, welcome to all of our PCPs from our clinics. So also want to welcome our family medicine folks, residents, and some faculty. And let's see, Dr. Cortez is not here. We have our dermatology team. We have Dr. Rabinovitz. We have Dr. Davis, and we have Dr. Buchanan. So welcome to all of you. And then we have our whole TeleDerm team, most of us being here in the hub here. We've got Kenza Mamuni, we've got Marsal, we've got Brenda Santiano. They're all running the controls. And Kenza will be giving you the link for the CME at the end, etc. And then we've got our 2-star medical students, Mackenzie and Gabby. So welcome aboard. And this is the time when we need you to write in the chat your name and your affiliation, if you're with a clinic, if you're a resident, if you're in dermatology, just to let us identify you a little bit better. And so now, if we can have the slides. Here we are. And to just quickly review the agenda, we've had our introduction. We will have our didactic portion from Dr. Kendall Buchanan on dermoscopic features of basal cell carcinoma. And then we will have one case presentation today by John Hetzel, who's a 4th-year medical student at the Medical College of Georgia here at Augusta University in lovely Augusta, Georgia. And then we'll end with a wrap up and announcements. So, and as I said, Dr. Patton is not here, at least not yet. So we'll start, as we always do, with a few announcements. So here we are, part of Project ECHO, and the mission of Project ECHO is to move knowledge instead of people. And next slide. The goal of our TeleECHO TeleDerm sessions is to improve knowledge about telemedicine at the local level and to use distance learning approaches to overcome the dermatological health disparities faced by people living in rural areas of the state of Georgia. So let's see, where are we? Next. Okay. So reminder that TeleECHO sessions are recorded and that you are consenting to be recorded by participating. A reminder that as we are discussing any case studies, do not mention any PHI. And then our final slide will have information about the CME. And at any time, if you have any questions about our program, feel free to email us at teledermatology@augusta.edu. And Project ECHO collects sorts of information about these sessions, which is used in communications and reports, but it is all confidential information. Next. And Zoom reminders to keep your microphones muted when you are not speaking, but remember to unmute yourself when you do speak. If you have questions, type them into the chat, raise your electronic hand, or just speak up. When you do speak up, please introduce yourself with your name and affiliation whenever you speak. Use your camera as much as you can, use your gallery view, and if you have technical problems, either use the chat or email kenza@kmamooney@augusta.edu. Okay, and at this point, we will start with our didactic presentation. I'm happy to introduce our beloved Dr. Kendall Buchanan, who is in our Department of Dermatology, and she practices at AU's Care Center for Dermatology in Aiken, South Carolina, across the river. And today her talk is about dermoscopic features of basal cell carcinoma. So take it away.
All right. Let me just okay. So today we're going to talk about dermoscopic features of basal cell carcinoma. So again, we've reviewed the algorithm many times, but very important to continually to go through it every time you're evaluating a new skin lesion. So as you recall, we've talked about melanocytic nevi already. We'll soon be talking about criteria for melanomas. Today, we're going to talk about non-melanocytic skin lesions and specifically basal cell carcinoma. So since we had a little bit of extra time today, I'm just going to give a little background about basal cell carcinoma, just because, you know, if you can recognize it clinically, then you can confirm what you're seeing with dermoscopy. So very important to keep these things in mind. These are just some examples. So on the left, this is what we call a superficial basal cell carcinoma. It usually presents as a pink, slightly scaly, thin plaque or patch. And then nodular basal cell, these are typically the more common types of basal cells that you see, and commonly described as a pink pearly plaque or papule. You can see how shiny the photo in the middle appears. Another example of a superficial basal cell, and then in the middle, you also see a pigmented nodular basal cell carcinoma, which we will review today. And then here's an example of an advanced basal cell carcinoma. As you can see, this is a rather large plaque. It has a central area of ulceration and then a pearly rolled border. So this has probably been here for 10 or more years. So as I mentioned, basal cells typically present non-healing pink and pearly papules with rolled borders. They occur in areas of chronic sun damage. They can bleed or itch, and they can also be asymptomatic. They tend to grow pretty slow and enlarge over time. Usually patients will complain of a spot that won't go away. It will commonly bleed and become crusted. There's different types. The most common types are nodular and superficial. Nodular accounts for about 50 to 80%, and superficial accounts for about 10 to 30%. Other types include infundibulocystic, morpheaform, and infiltrative, the latter two which can be slightly more aggressive. So we won't get into too much detail regarding the pathophysiology, but essentially this is in the hedgehog pathway of mutations. There's a couple of genes involved, smoothen and patched, but essentially these cells and genes are mutated in response to ultraviolet light. The good thing about basal cells is that most of these are small and amenable to treatment. Locally advanced comprise less than 1%, and these very rarely will spread to other distant sites. So very uncommon to see a basal cell spread to the lymph nodes or metastasize. Occasionally you can see bone involvement, but this is also extremely uncommon. And this is just a little schematic showing how both UVB and UVA light can cause these mutations in DNA that predispose individuals to developing basal cell. There's also a few genetic conditions that can predispose you and have different risk factors, but these are fairly uncommon. And so this is the most common human cancer in the world. About 1 in 5 will develop basal cell carcinoma in their lifetime. It's probably a little bit more than that for Caucasians. Affects about 2 million Americans annually, and the incidence is increasing and is expected to continue increasing until at least 2040. And so a lot of the risk factors we've gone over in previous lectures, but UV exposure is number 1. Also fair skin, red or blonde hair, inability to tan, male sex, increasing age, immunosuppression, ionizing radiation, and genetic conditions. So now we get into the fun stuff. So basal cell and features on dermoscopy. And these are photos that you can see the variety of different types of basal cells that we'll be going over today. So we're going to start with a case. So this is a 57-year-old male. He presented to our Augusta University clinic with a pink to red thin plaque on his left arm, and it had been present for many years. It was not healing. He did have a history of chronic sun exposure. So on exam, we evaluated this with both non-polarized and polarized dermoscopy. With polarized dermoscopy, you can actually see the vasculature better, as well as the white shiny structures, which we will talk about. So going through our algorithm, immediately we recognize that this is non-melanocytic. There are no features suggestive that it's melanocytic, no network, no globules, or homogeneous pattern. And then the features that we see include pink, red, milky white areas, shiny white blotches and strands, and a focal area of ulceration. So, and like, as I mentioned, the shiny white areas are usually are seen better with polarized light. And this is an example of this is the pathology. And so what you can see are these basaloid buds hanging off the epidermis. And so this was consistent with a superficial basal cell carcinoma. These are our main dermoscopic features of basal cell carcinoma: arborizing vessels, spoke wheel structures, leaf-like areas, blue-gray ovoid nests, multiple blue-gray dots, globules, shiny white blotches and strands, and ulceration. So arborizing vessels, these are often called tree-like or serpentine. They are very bright red, often sharply in focus. And this is a great example of a nodular basal cell. You see this, these vessels that are sharply in focus, a broad base vessel, and then small branching vessels toward the periphery. Another example, not quite as obvious, but again, on dermoscopy, you can see that the vessels are sharply in focus. You have a broad base vessel and then smaller branching vessels. You can also see leaf-like areas, spoke wheel structures, and concentric structures. And these are often all 3 or sometimes 1 or 2 present in the same lesion. So we'll start with leaf-like areas. these are brown radial lines that are connected to a common base. They can fan out and resemble a leaf shape. So this is a beautiful example of these little leaf-like areas. They often, to me, have somewhat of a smudged appearance, which can sometimes be helpful to distinguish between pigmentation seen in a melanoma. And here are some more examples here, these kind of areas. And you can see that along with the dermoscopy image, we have provided these pathology images, which show the superficial basal cell coming off of the epidermis. So occasionally it can be very tricky to distinguish a basal cell carcinoma from a melanoma. I actually just today sent Dr. Rabinovitz an image of a case that I saw, just making sure that it was indeed a melanoma and not a basal cell. So when you're trying to decide between the two, these can be some helpful tips. So leaf-like areas tend to be a little bit fuzzy, not always at the periphery, and they can radiate toward or away from a central body. Whereas in melanoma, these are called streaks, and they tend to be discrete and narrow and always radiate away toward normal skin, and they will often converge centrally toward a blue-white veil. So just keep this in mind if you're trying to distinguish between the two, because sometimes this can be very challenging. And leaf-like areas are highly specific to superficial basal cell carcinomas. This is another example. These are called spoke wheel structures. They're variants of the same. So often this is just corresponding to pigmentation from basal cell carcinoma that's arising from the epidermis. So you can see these spoke wheel structures here and an example of the pathology. Concentric structures, again, variants of the same. You will often see these small brown dots that have kind of a circular area surrounding them. And some more examples here. As I mentioned, not uncommon to see all three in the same lesion. So here you have your spoke wheels, your concentric structures, and your leaf-like areas. And these are highly specific for superficial basal cell carcinoma. Just more examples here. The next feature we'll talk about is blue-gray ovoid nest. So these are basically the same as multiple blue-gray dots and globules. They're simply different sizes. So starting with the blue-gray ovoid nest, these are large brown blue to gray globules. They often make up more than 10%. And these correspond to basaloid tumor islands in the dermis, basically meaning that when you see these, you can expect that the pathology will show a nodular basal cell. And you can see this melanin pigment here within the basaloid tumor island. So because of how deep that is, due to the Tyndall effect, it's reflecting as a blue color on the skin surface. And here's more examples of those blue-gray ovoid nest. So blue-gray dots and globules, again, these are just smaller than ovoid nest. They're non-aggregated blue-gray round and oval structures. So this is an example here. You see these almost perfectly round blue structures that are centrally located in this lesion, and there's an area of ulceration as well. So we often refer to this as buckshot scatter. And so it's just an analogy that we use. So birdshot scatter, these are very small pellets that are located within the bullet there. And so basically, whenever you think about birdshot scatter, this is more going to be very, very small. And you can think about this in terms of melanin deposition or melanophage. Buckshot scatter, so these pellets are going to be larger, and whenever you see this type of presentation, this is going to correspond to more nodular tumor islands. And again, this is just a metaphor for how we use to describe different features. So here are some more examples, these non-aggregated blue-gray round or oval structures. And this was a basal cell. And then you have more blue-gray dots and globules that correspond to small tumor islands in the dermis. More examples here. Shiny white blotches and strands. So this is one of my patients from Aiken. She presented with the skin lesion on her lower leg. I just wanted to point out the golfer's tan lines here. Essentially, blotches are white, discrete, small or large round structureless areas, and strands are thick or thin white lines. These are often parallel but not orthogonal. And these can only be seen with polarized light. So there's your blotch and then your strands. And I have some more examples to show. Another example, this is another picture of a patient of mine with a pink thin plaque on the lower leg. And here we see again these blotches, which are the small round structures, and strands, which are the white lines that are oriented in parallel. And this was a superficial basal cell carcinoma. This is another case, a patient of mine. He had a history of melanoma, and then he actually pointed this spot out to me, this small, like slightly scaly pink area that was within his tattoo. So as you can see, what we see are multiple shiny white blotches and strands. And this is important. So this is usually due to altered collagen and fibroplasia. So the white shiny structures can be seen in a variety of neoplasms and can often be the only dermoscopic feature present. So it's important that when you see these types of structures, you have a differential in mind. And then this was the example from that case. So this was the basaloid tumor island that was coming off of the dermal epidermal junction. And then you can see the tattoo pigment in the dermis. So this was a case I saw last week. So clinically, this was concerning for a basal cell carcinoma, shades of pink melanoma, squamous cell carcinoma in situ, or dermatofibroma. I wasn't entirely sure. I looked at it with dermoscopy. So the image on the left is non-polarized and the bottom is polarized. And when I saw this image, I was probably more concerned for a shades of pink melanoma because of the orthogonal nature of the lines. And you can see there, these are just these beautiful, what we call short white lines or crystalline structures. And these are typically seen in melanoma and actually have an inverse association with a basal cell. However, I biopsied it and it came back as a superficial basal cell carcinoma. So sometimes it can be challenging, but again, shiny white blotches and strands are very common and when seen together, are highly specific for basal cell carcinoma. So our last feature, I believe, is ulceration. So these are shallow erosions, or they can be full ulcerations that occur, very common in basal cell. Sometimes it can be challenging because they can actually be covered with blood or crust, and they will occasionally manifest in orange hue. So this patient pointed this spot out to me. One place that if you ever find a basal cell carcinoma in the nasolabial fold, you will always check there every time because oftentimes as we age, this line becomes more prominent. So you have to make sure to really inspect that area. And this was all that I saw on dermoscopy. So, sometimes you have to just kind of have that suspicion. So I did biopsy this and it was a basal cell carcinoma. But like I said, you will occasionally only see this. Another patient of mine had this spot on his nose. On dermoscopy, you can see this kind of orange yellow crust. And then on the outskirts, you see the more typical arborizing vessels or telangiectasias that you see with basal cell. Another patient of mine, this was the first lesion that we looked at with the arborizing telangiectasias. She had several more on exam. And so in this case, you can see examples of leaf-like areas, fine thin telangiectasias, and multiple small erosions with yellow-brown crust. And so this was consistent with a superficial basal cell carcinoma. And in nodular basal cell, you often see larger ulcerations that usually are about greater than 10% of the surface area. Other notable features we'll talk about: twisted loop vessels. So these are the second most common vessels seen in basal cell carcinoma. They can resemble hairpins. They're not specific, and they are often seen in recurrent basal cell. So here you have just an example of those twisted loop vessels. And another example here. Again, you can see this kind of scar area. So this was a recurrent basal cell. May globules, this stands for multiple aggregated yellow to white globules. This was a patient that Dr. Rabinovich saw. You can see clinically, doesn't look like much, a white, shiny, thin plaque. And so on dermoscopy, what you see are these multiple aggregated white and yellow globules. And so these are seen with both polarized and non-polarized light, and they correspond to calcification. And there you also see arborizing vessels. So this was the pathology, and as you can see, this calcification in the dermis here. This is a relatively newer feature that's described for basal cells, but it is 6.5 times more likely to be seen in high-risk subtypes. So this would include infiltrative or morphiiform, and this has not been seen in superficial basal cell. So in summary, basal cells have multiple unique features that are visible with dermoscopy. When you're thinking about superficial basal cell, you will often see fine, thin telangiectasias, shiny white blotches and strands, leaf-like areas, spoke wheel structures, and concentric structures, which are essentially variations of the same feature, and small superficial erosions. Nodular basal cells will usually have larger arborizing telangiectasias, blue ovoid nest or blue-gray dots and globules, and larger ulcerations. These are my references. And then up next, we're going to talk about squamous cell carcinoma. And then following that, I believe we're going to talk about melanoma. So that is all.
Okay, thank you very much. Do we have questions for Dr. Buchanan?
Hi, the family medicine residents have a question. Hold on one second. We're getting her to the microphone.
Hey, Dr. Buchanan, can you hear me?
I can.
Okay. So you were saying the like shiny blotches and the like white patches, those are like specifically like pathognomonic for the basal cell, or do we see those like in other like structures as well, or is it specifically like in the basal cell?
No, there's different types of what we call shiny white structures. The shiny white blotches and strands, when seen together, are very specific for basal cell carcinoma. But with that being said, you can see short white lines or crystalline structures that can look very similar that are often seen in melanoma. You can see other things like rosettes, which we've talked about before, which are shiny white structures in a floral arrangement. Those are seen with actinic keratosis, usually in squamous cell carcinoma. You can see multiple shiny structures located centrally in things like dermatofibromas. But typically, if you're thinking clinically that something could be a melanoma and you see shiny white structures, you would also want to look for other melanoma specific features as well.
Okay, makes sense. Okay, thank you.
There was a question in the chat.
So I think the question was regarding basal cell carcinomas in non-white skin. So, basal cell carcinoma is, it's a skin cancer, so it's not going to be as common in darker skin types. With that being said, we do see basal cell carcinoma in dark skin types, chronic sun damage, sun exposed skin, especially in like the lighter Fitzpatrick types, like 3 to 4. So the image I showed in the beginning of a pigmented basal cell carcinoma, those are going to be more common in darker skin types. So you would expect to see those blue-gray ovoid nests, the leaf-like structures, more commonly in a patient of a darker skin type. And if Dr. Rabinovitz, he might want to add along something to that as well.
So with individuals with Fitzpatrick 5, 6 skin, these are individuals who are heavily pigmented. So with the Hispanic population, very often you'll see, with the nodular basal cells, you'll see the blue globules, you'll see the ovoid nest. In individuals with Fitzpatrick 6 skin who are very dark, my best spoke wheel structures was on a gentleman from Jamaica who had beautiful spoke wheel structures. So these structures can be seen both in individuals with fair skin and dark skin. Basal cell carcinoma is not as common with individuals with very, very dark skin, but it can occur over a lifetime.
Detecting these lesions with the tattoos. So that must be difficult.
Well, I know that recently Dr. Rabinovitz has a case that he saw, and I just saw this case that I showed today. So it can be difficult. And, sometimes you will miss it because it's, that could have been anything as far as I was concerned clinically. But that's why dermoscopy is so valuable, because, it doesn't look like much clinically. And then you go in with your dermatoscope and those shiny white structures are, popping out of the screen. So things become a little bit more obvious.
I think tattoos act like camouflage, and you just have to go over them much more closely, especially if they're detailed. And so you really have to, and people have multiple tattoos and they're larger these days. So you really have to spend extra time looking at those with your eye. And again, if you see anything, getting your dermatoscope out.
Okay, any other questions, or shall we move on to our case presentation? Okay, well, thank you very much for that, Kendall. I'm particularly interested because I have a basal cell on my leg right now that is I'm waiting to have taken care of, that Dr. Davis diagnosed. So we can move now along to our case presentation by John Hetzel, a fourth-year medical student. John, you can share your screen now.
Can everyone see the presentation?
We can see it, but we
In
it's
presenter
not,
mode?
yeah,
Yeah. Do it this way. How about now?
it's great. Thank you.
All right. So my name is John Hetzel. I'm a fourth-year medical student, like we mentioned, and this is a case presentation. I have a 76-year-old female. She has a history of numerous seborrheic keratoses. She's here for a routine skin exam, and incidentally finding a tan brown and blue-gray spot on her mid-upper back. So because of its location, it's been present for an unknown duration. Some interesting features, or some features that stand out, is that it's kind of got some distinct areas. The superior portion is kind of more tan brown and dark brown, and then the inferior portion is more blue-gray. Additionally, there is a central excoriation or potentially an ulcer. Based on its location, probably more likely an ulcer in this case. Otherwise, no additional features clinically. So I mean, based on our history and just looking at it, we have, it's kind of a waxy, stuck on brown plaque, thin plaque with kind of an inferior blue-gray thin papule. Her history significant for many seborrheic keratoses, so that's definitely on our differential. But because of the inferior portion, kind of more concerned about potentially collision lesions with things like blue nevi, pigmented basal cell carcinoma, or melanoma. And so this is just a different figure of the kind of the two-step pathway. We have a pigmented lesion. We're going to determine if it's melanocytic or non-melanocytic, and then go from there. So step one, looking at it if it's looking to see if it's melanocytic or non-melanocytic. And so there's notably an absence of pigment globules, networks, these kinds of things that would kind of immediately stand out and tell you this is melanocytic. It's also lacking kind of homogeneous areas of blue or brown. Though the inferior portion does have a bluish area, it is not really homogeneous in this case. So we've determined that it's non-melanocytic here, just by its lack of melanocytic features. And so we're going to move to step two. And because the lesion has kind of two distinct regions, we kind of evaluate them, separately in this case. The superior portion has a number of features like milia-like cysts, comedial-like openings, fissures and sulci, that kind of differentiate it from the inferior portion where those are notably absent. Looking at the inferior portion of the lesion, we can see some very sharply defined arborizing or branched vessels, kind of radially around this blue-gray ovoid nest. There's one kind of large one and then a smaller one more inferiorly. Again, these things are absent in the superior portion of the lesion, kind of telling us that we've got two distinct things going on here. So, looking at the superior portion of the lesion, it has features that are pretty characteristic of seborrheic keratoses. Those comedial-like openings, milia-like cysts, fissures, and sulci. But the inferior portion of the lesion has features that are characteristic of basal cell carcinoma. However, it is kind of important to separate the things like the blue-white veil that Dr. Buchanan mentioned and these blue-gray ovoid nests. In this case, the blue-white veil kind of represents kind of more of a palpable area. This doesn't really have that kind of whitish hue. And then in addition to that, we have these arborizing vessels, which are fairly specific for basal cells. So and also we have no melanocytic features, so we weren't really super concerned about melanoma. However, the basal cell features warrant a biopsy in this case. So we have a shave biopsy, and on the shave biopsy, we can see that there are indeed two distinct lesions. The superior lesion is a seborrheic keratosis, and so you can see those milia-like cysts, the fissures, sulci, very plainly apparent on the biopsy here. On the right-hand side, we have very different features. We have basaloid nests. You can see, I'll show a little closer here in a moment, as well as some sclerotic stroma. So here's a closer up view. So you see on the left-hand side, we have some very basaloid appearing deep tumor islands, as well as more superficial tumor islands. And then on the right-hand side, we have these collagen nests or this sclerotic stroma, which are also indicative of what this specific basal cell is. And so it was actually diagnosed as an infiltrative nodular basal cell carcinoma with some areas of sclerosis and then an incidental seborrheic keratosis. Just looking back here at the kind of broader area. And so in this case, it's interesting because, in a background of many seborrheic keratoses, it's very easy to overlook lesions that are collision lesions or things that maybe look like seborrheic keratoses. In this case, there was something more sinister disguised by that background. However, looking at on dermoscopy, we can see much better that there is a distinct superior portion to the lesion with features that are very characteristic of seborrheic keratosis, and then an inferior portion of the lesion with features that are very characteristic of basal cell carcinoma. So it really helps us to guide our differential and then leads us to do a biopsy of this lesion rather than just skipping it over. And then so the questions would be, how does the management of an infiltrative type basal cell carcinoma differ from that of a superficial basal cell carcinoma? And these are my references. This is a question for the ECHO team. Anyone care to answer?
I can speak to John's question. So, because infiltrative basal cells can be more aggressive, I'm actually having this patient see Dr. Potter, our Mohs surgeon, and she's going to perform the Mohs micrographic surgery. I believe it would also be completely acceptable to perform an excision here. Less acceptable, in my opinion, to do something like an ED&C, just because of the patterns that we saw. The blue-gray ovoid nest is suggestive of a nodular basal cell. And then also based on the pathology report, the infiltrative nature, you would most likely want to make sure you got clear margins on this type of skin cancer.
So just to add, for those who do not know what Mohs surgery is, it's considered our Rolls-Royce treatment to treat a basal cell carcinoma. And when you have a basal cell in a high-risk area for recurrence, Mohs surgery is considered the treatment of choice. On a truncal area, as Dr. Buchanan mentioned, you could either have a surgical excision, a wide surgical excision. Normally we take anywhere from 4 to 5 millimeter margins and suture the skin, as opposed to Mohs surgery. Mohs surgery is a method where you numb up the area and you cut out the area that you believe is a skin cancer. The scalpel is held on a slight horizontal plane. So when you remove the tissue, it comes out almost like a pancake. You take that pancake, you flip it over, you cut it into smaller pieces, you number each piece of tissue, and you make slides looking at the entire skin edge and undersurface. You color the undersurface with 2 different dyes, freeze the tissue, and make slides of the tissue. The surgery normally takes about 5 or 10 minutes. It takes about 45 minutes to an hour to process the tissue. If it's clear, you're done. If it's not, you go back to the areas where it's positive, and you continue to do that till you get the area clear. Once it's clear, a Mohs surgeon, such as Dr. Potter, would then repair the area. And the cure rate with Mohs surgery is considered the best. It's anywhere from 97 to 98.5%.
We have a question from the chat. Someone can read it.
Would you have this patient feel for their lymph nodes for any period of time? I know sometimes with squamous cell, providers will tell their patients to feel for lymph nodes.
I don't routinely after basal cell. I mean, I don't think there's anything wrong with that, if you did suggest that, but I think more commonly squamous cells will tend, especially of high risk type, and we'll talk about this a little bit next month, but if they're greater than 2 centimeters, poorly differentiated, with perineural invasion, then you would definitely be more concerned that there was possible lymphatic spread. But typically for basal cells, unless they're on the head and neck and you're concerned about potential erosion into bone, things like that, it's probably not routine that you would ask the patient themselves to feel their lymph nodes.
Thank you.
I agree. I was going to say that you might make people very nervous too, because basal cells are uniformly, we tell people not to worry too much, and these are usually small and easily treated and they don't metastasize. And so, as Dr. Buchanan said, if they're very large, that might be a different story, but 99% of these things are going to be small and not, we're not going to have that worry about lymph nodes usually in those folks. Squamous cell is a different story.
Counter a lesion that is, as this one was, that is partly basal cell and partly seborrheic keratosis? How often do you have an overlap of two different diagnoses within the same lesion or area?
So collision tumors are not uncommon in our older population. That is, we see these with individuals who have sun damage. So in a sun damage area, you can have a collision of a seborrheic keratosis with a melanoma, a basal cell, a collision with an actinic keratosis as well. They're more difficult when they're on the face, because when you have a seborrheic keratosis and that seborrheic keratosis gets larger as it does over time, sometimes it'll blend in with a very early melanoma. And those are much more difficult to diagnose. And that's where dermoscopy plays a very, very important role. But they're not uncommon in our older population.
I always tell people that just like tattoos are camouflage, if you have a lot of seborrheic keratoses, that can be camouflage too. And you really have to pay attention and look within that back area, because if someone's got 40 seborrheic keratoses, it's easy to miss something that's a little unusual.
Okay, well, that was a very interesting case. So if we don't have any more questions, we can move on. And if we can have our slides back. Certainly want to thank both Dr. Buchanan for her presentation and John's presentation, very, very interesting. And I have a reminder here for our clinic primary care providers that we are having a Zoom meeting next Wednesday, October 12th at 4 p.m. And that is for the purpose of some updates and discussion of how things are going. We'll send you emails and try and get an agenda out for that. But I do want to remind you that we have that next Wednesday. And then our next session, as Dr. Buchanan said, we'll look at dermoscopic features of squamous cell carcinoma. We have one case presentation scheduled by Lori Liz Akins, a medical student, but we are looking for a volunteer from our clinics, one of our PCPs from the clinics who might also present a case presentation. So please contact me or Brenda and let us know if you are interested in presenting. And Dr. Buchanan will be happy to help guide you along the way with your presentations. So for CME, CNE credit, the code is listed 9095 and the number to text is there. I think it's in the chat, and you'll also get an email about that. Also a reminder to the clinics that we periodically ask you to fill out a brief questionnaire survey, and so please do that. We need that information for our evaluation purposes. And if there are no other questions or things to discuss, I think that we can say goodbye. And I'd like the TeleDerm team to stay online for a few minutes, but the rest of our clinic folks and other guests are free to sign off. So thank you for attending, and we'll see you in a month on November 7th.
Thank you, everyone.
Bye.
Bye. Thank you.
Yeah, thank you.
Bye, everybody.